It is, thank you. It is a huge pleasure to introduce Associate Professor Josephine van Olmen. Josephine has been a visiting academic with the with CRiHSP, with the Center for Research in Health System Performance, and also with the Department of Family Medicine at the National University Health System. Over the last, it will be close to a year soon. And within CRiHSP, she has been leading work in relation to the effective coverage in Asian countries, and work that is currently we're still conducting and scoping, but also in relation to a number of other areas of primary care and primary health care. She benefits from a wealth of experience internationally, both in African countries, but also in Southeast Asia. And it is, this is not the first seminar that Josephine has given to us. And we are very much looking forward to this one on an area in which she has a substantial expertise. Over to you with this slight rotation. And I don't know, and you wanted to say something in relation to the...
Yes, hi everyone, and thanks for joining. Should anyone have any questions, please use the Q&A box to ask your questions at the end of the talk. Thanks.
Okay, ready to start?
Go ahead.
Yeah, thank you very much for giving the opportunity to talk a little bit about health systems and the dynamic aspect of it. Upon request, this seminar is a bit of an introduction to what a health system is for those who have not worked extensively in that area. So I know that on the participant list, there were also people from the School of Public Health who might already have much wider experience and working tools. I would gladly invite you at the end of this talk, which is not very long anyhow, to contribute so that we make this a common resource experience. The talk is mainly based upon work I did long before I came here, which was writing a booklet on what a health system is, exactly for people who were pretty novice to the area. And I brought the booklet also for those who are here. So there are 2 copies somewhere here around if you want to read them. It's easy reading, and it gives you basically the flavor of the first half of what I'm going to tell today. So yes, health systems are really a very vast area in itself. You can talk, in fact, Gemma and I came from a seminar 2 weeks ago where we spent 4 days of talking in depth to various aspects of it. Maybe a bit good to position the research domain before we go further. So I think traditionally many people have first been in clinical research, or who have been coming from health management areas, do what we call health service research. So that's about organization, a lot about outcomes, or utilization outcomes or quality outcomes. Health systems research, or when it was framed, the very first global seminar, which was there in 2012, I think in Montreux, it was framed as health systems and policy research, and was framed as something much more wider than the healthcare services, and very explicitly also put in the fact that policies which are made implement all levels of the health system. So they were part and parcel of research on health systems, and that topics could be both international health, the international structure of global health and how health systems are shaped, national health systems, but also local health systems, let's say district level or urban health systems nowadays pretty popular. And how they interrelate and influence each other. So very much branded as an interdisciplinary and multidisciplinary research domain. And for both areas, I think there are key references, which I'll share the slides with you, and in the note pages, you can find some core introductory readings. I'll give you a bird's eye view on health system frameworks and how they have developed over time. Then how the systems thinking and the system dynamics thinking helps you to better understand a health system and the behavior of a health system. And then the last part is a short introduction in methods to assess system dynamics, for instance, on workforce planning, scale-up interventions. I take you back into history and walk you along how health systems and health system frameworks, more particularly, were developed over time, and by whom, and also what were the agenda of the stakeholders who were driving them. And I highlight first see how that works. Yeah, the key year of 1978, the Alma Ata Declaration for Primary Healthcare and the Health for All agenda. And that era, the bigger political and international context was one of decolonization. Oh, wait. I said decolonization, and a lot of also know-how on how to successfully implement community initiatives in several Latin American countries, but also, for instance, maybe the barefoot doctors in China were a big successful event. And there was a lot of appetite to scale those things up and a lot of advocacy to add social issues related to health into action plans. And the WHO and UNICEF were at that time the global health actors and movers behind that agenda, and values which were very strongly propagated in the primary healthcare approach were universal access, equity, and participation, and intersectoral action. These are still the pillars of primary healthcare. However, it did not happen, not to the full at least. Times of economic recession came, and the IMF pushed for reforms in many of the low-income countries, which really reduced budgets for social services. And also, there was resistance from health professionals within the health system and a lack of political will to implement programs driving social change. And within health systems, that meant that there was an increasingly a push towards a selective implementation and interpretation of primary healthcare, with a focus on a small number of programs, maternal health care, HIV not yet by that time, but tuberculosis, sanitation, and very often also very vertically organized, meaning you had a national program with a national budget and specific targets related to that program, and everything was driving towards optimizing the outputs of such programs at the neglect probably of other things which were happening in the system. Also very much focus on resource management, on actors and on who is paying and how that can be made efficient and more sustainable, focusing on national sustainability. So that was also the time that the private sector came in, and there was a lot of thought on how you could contracting in versus contracting out and make collaborations between the private sector and the public health system, let's say. So focus on national and even local sustainability of hospitals, for instance. It also led to the development of local frameworks for district planning, and these ones are still or even maybe again becoming relevant, that how do you in a local health system organize service delivery in the most efficient way? And nowadays that is very much linked to a population health approach, but then a population within a particular given district. So work done then comes back, I'd say, in the current times. We move a bit towards the 90s, and that was the time of globalization, Millennium Development Goals, and the World Bank becoming much more and more involved in health systems and health system strengthening. And the DALI concept comes up, Disability Adjusted Life Years, a measure for burden of disease. But more than that, it also became a metric for valorizing health and for prioritizing interventions. So that's strengthened in a way best by rhetoric and targeting programs which would lead to most health impact. New era, I'd say, again in around the millennium, when the global donor landscape led to big dominant philanthropy organizations with targeted programs for the big 3 diseases, and by that time HIV, AIDS, and tuberculosis, and malaria. Targeted programs with accountability, because these MDGs came with targets, so we had to measure, and a focus on performance. So also by that time, comparative health system frameworks came along, which try to define and measure performance. We'll come to that a bit later. It asked for a counter reaction, I think, where people embraced the concept of complexity and say, well, all targeted approaches, well, but in fact, there's more happening beyond what you measure as your area of focus. And maybe what is happening around is you should take it into account. So yeah, many different frameworks emerging, focused since 2015 very much also on universal coverage and effective coverage and coverage with quality, which we go into a bit more in depth now. So that historical analysis ended by the 2016. I could go on, but already then I think a few of the history lessons which I always emphasize is that frameworks are not neutral. They develop in reaction to one another, and partly in line with prevailing paradigms of the time, but partly also as a response to the needs of those who develop it. Largely speaking, you could divide perspectives of health systems in 2 arenas. There are those who propagate an engineer or a mechanistic vision that you can steer reform by controlling certain knobs, and those who emphasize that health systems largely develop in reaction to contexts and precedents. And that rift in visions, I'd say the 2 worlds come together, but let's still, for the sake of the narrative, position it as a rift, has implications for the evaluation of health system performance and also for how you look at health system strengthening. Okay, to give you a flavor, I'll quickly run through a few of the most dominant frameworks which have been developed over time. And the health system building blocks and the 2000 World Health Report by Murray and Evans is arguably the mother of all health system frameworks. The World Health Report of 2000 was the first one, I'd say, to really delineate what is a health system and to define its goals. And with the goals, its functions. That was really unique at the time. And those goals still largely are set. They've been redefined slightly, maybe a few more. We have now quintuple aim health systems, but by and large, these are still commonly understood as the most important goals of a health system. Those authors also tried to link goals and functions through performance assessment. That was the least successful part of the exercise at that time. From there, the WHO continued this thinking, and in 2007, they came up with the 6 health system building blocks, which you can see on the right side. Service delivery, health workforce, information, all the medical products, which include medicines, vaccines, technology, financing, and leadership or governance. Also, these are still very much bread and butter for every health system actor. This was really an example of, let's say, an engineering vision of frameworks, the control knobs frameworks, by partly the same authors as the World Health Report, and they came from Harvard. Maybe that doesn't surprise. So they actually post that a health system has certain control knobs, and by steering those, you can improve efficiency, quality, and access towards the final goals. And to walk through a few of them, because it helps you thinking about what are the domains in health systems research, and what do they entail. Health financing, that means the way resources are mobilized, but also how resources are pooled and allocated towards different providers or different sectors. And that determines the amount of resources you can mobilize, the fiscal space in many low-income countries, for instance. Well, not only, I'd say in all countries nowadays an issue. But also what we call allocative efficiency of a health system. Do you spend all your resources in specialized care, or do you prioritize or even measure how much you spend on primary care? I can tell you, when I tried to look up how much Singapore spends on primary care, it wasn't to be found. Who has access to care, and also the financial risk protection that a health system provides to its population. And that links directly and indirectly to equity. Another one is macro organization, and that governs how the delivery of health services is organized. Most importantly, I think, the role of the public and the private sector, and also the level at which the government is responsible. So how much decentralization has steered through the system. What is the power of both, for instance, hospital administration to manage and generate their own income? How much risk pooling is there across areas, across institutions? That has a direct influence on quality and efficiency, and also on the cost of healthcare. Also, that links to incentive structures, which are shaped by the payment system. Do you pay salaries, or do you pay by performance? Or is it a purely privatized system? All those things influence behavior of providers, but also steer demand. Well, regulation that involves the use of power by the state to alter behavior of organizations. I talked a bit about that with incentives, but also individuals. And I think with chronic diseases and health promotion coming up, this also becomes again a relevant control knob. How much do we induce the population to health promoting behavior, or how much coercion can you put in? These are increasingly relevant and widening yeah, let's say steering knobs which a government has. Next framework, yeah, I already said that from the 2010s, the focus became on universal health coverage. That is I'd say a rather tangible goal which you can strive of. And this cube, in fact, this cube was in the 2010 World Health Report and focuses very much on how you finance universal health coverage. But I must say, I really like the metaphor of the box, and we've used it also even without financing to look, for instance, on how you could reach universal coverage of an integrated care package. And then we adapted the access to that. So what the metaphor shows is when you think of expanding coverage, you can do that in different directions. On the horizontal axis, you can extend the package to more people. In this case, make sure that the people who have financial coverage, you increase your health insurance programs. For instance, in the Philippines, they're very busy now with expanding the coverage of PhilHealth to the entire population, I think even in Indonesia. You can talk about the depth, that's the diagonal line, which benefits are covered. There's a lot of discussion and development has been over time in if you come up with a health insurance, if it's community-based, which is usually small-scale local insurance schemes, or a national health insurance scheme. And what should be the priority? Should you first make sure that impoverishing health expenditures like a hospital admission is covered, or should you make sure that primary care is covered so that people at least access that? Well, there's an entire debate and research about that. But in the end, I think the common sense for national health insurance programs is that they cover a minimum package of activities. And what that minimum package is, that depends very much on the country. If you have, well, I think HIV antiretroviral treatment is in every package. But depending on the burden of disease, yeah, dengue can be in or out. There is even in my own country, Belgium, a very hot debate whether extremely rare diseases should be in that package or not. They're extremely costly because pharmaceutical companies tend to keep the patents for those treatments in themselves. And it is, in terms of burden of disease, there are only a handful of people suffering from that. But when you are that person and you don't get your treatment covered, you are in big trouble. So all kind of equity and efficiency values which are basically colliding, and which is why what is in this package needs to be based upon technical measures, but also is fundamentally a matter of dialogue in a hopefully democratic system where people debate about this and try to share and resolve conflict together. Yeah, in a democratic way. And the last, the vertical X is to reduce cost sharing, or if you talk about a benefit package, you increase the amount of services. So for instance, you say, okay, now we have integrated care, but we want to put the e-health component on top of that package. So you expand. So yeah, the metaphor of expanding universal health coverage. Back to performance assessments of health systems. This is the framework developed by the European Observatory. And you can see a lot of things you can recognize from the earlier frameworks. Yeah, some notable changes. The word satisfaction, or I think it was responsiveness, has been replaced by people-centeredness. Think of a concept which has a bit more hands and feet and a bit more recognizable for clinicians. And what is also explicitly there is the social determinants of health. It's something outside of the system, but of course, extremely important. Yeah, very helpful. They have elaborated it for the key 4 functions on the left side in very, very great detail. And it provides a useful strategic roadmap on how you can improve performance in your health system, and indicative for, I'd say, relatively mature health systems, like in OECD countries. It's not a coincidence that this framework is elaborated by the European Observatory. Then it said there was a lot of focus on coverage, but very soon already, critical people started to say, coverage of what exactly? And not only coverage of what, but also coverage how. Coverage without quality doesn't mean a lot. What if the quality of what is offered is so poor that it doesn't render results? And I've happened to work in countries, in hospitals, in primary care facilities myself, where I've been witnessing that to a large extent for various reasons. But the debate has, not all, but there is a second parallel or interacting debate between those propagating coverage, those who say, well, we should really not talk about coverage without quality. That doesn't make sense. But even I come very much from a chronic care and NCD scale-up approach, and there in Cambodia we had this very discussion 3 years ago. Should we expand the primary care? There is a WHO program for essential interventions for non-communicable diseases. It's very well laid out. And the WHO said, we want to scale up this package to all the primary healthcare facilities in the country, straight within 2 years. And then there was a group within the ministry said, no, we better go slowly, district by district, but make sure that when we implement it, the quality of what we do is really good. So this debate is ongoing as we speak, and these strategic choices have to be made day by day by people in ministries and funding organizations, because it was the World Bank who was funding the scale-up. So this, what you see here, is the framework with Margaret Kruk and colleagues developed in a Lancet commission in 2018, and in fact the foundation of the conference, which Gemma and I attended 2 weeks ago. And they developed this framework for identifying how a health system should be geared towards quality, and also define to a certain extent what quality is. And they said, well, you should judge a health system primarily, first of all, on the impact, because that's the raison d'etre or the justification of a health system. And the impacts should be threefold: should be better health outcomes, and also the equitable distribution. It should be the confidence that people have in the system, and it should be the economic benefit, so not at the detriment of making people more poor. And in order to reach that, you have to make sure that the processes of care are well. That means that you have competent care, but not only care, but also the systems around that. And think about chronic diseases where integrated care is very important, or collaboration between first and second line social providers. So that's competent systems, goes beyond the clinical measurements. And also, when I started my master in health systems, the legendary remark is, we don't run veterinary systems, we run health systems for people. So the user experience counts. It needs to be a place where people want to go. If they don't, they will avoid, they will go to any other kind of systems which do not necessarily render outcomes. So it's not only the outcome which counts, but also how people experience that. And well, maybe a bit of a sidetrack, but in the Ebola epidemic, the WHO in Congo, and even I think in the 3 West African countries, Guinea, and where the Ebola epidemic was so massive, but I knew it pretty well in Congo, the WHO had organized pretty effective interventions to deal with the epidemic. But for the people, it was not acceptable that they could not bury their dead, for instance, that as soon as an Ebola case came in, they were totally separated and there was no, they couldn't connect anymore. A bit, well, we can think about COVID, right? So if then people avoid utilizing the effective services, it's counterproductive. So yeah, you need to think about a responsive way of care. And then, yeah, amongst that are the 5 pedestals or foundations of what constitutes, which influences both processes of care and quality impacts. That's, I'd say, the structural elements. Around that, I forget to walk through, but you followed me. Around that, she has put 4 values of care. I could think of many more values, but I cherish it because I think we don't talk about values underlying certain choices enough. So it's good that they have identified here that underlying the entire performance framework, quality framework, it is about equity, it is about efficiency and resilience, and ultimately it's not for animals, but for people. Yeah, so there are many frameworks. There's still undetermined territories. What are the boundaries of a health system and how do you assess things outside of the health system? The social determinants of health here in the rainbow model really cover all the wider determinants of health. And we know 80% of health outcomes are determined by things outside of the health system. So why do we need health systems? Well, mainly to support those who get diseases nevertheless, and to relieve suffering and to treat. But that alone is probably not enough, or is not enough. And this became even more relevant, of course, when the planetary health debate came into the arena. And this health system framework was developed by WHO for identifying how health systems should become climate resilient. And you can still recognize the building blocks. They have adapted them. And 2 building blocks got a more widened approach with additional strategies. For instance, the health information system building block now also included much more specific climate information, disease surveillance, and monitoring of vulnerability of health systems. Service delivery also now explicitly includes how you deal with in-out and out-in effects. That's basically what is the effect of health services on climate, but also how does climate impact emergency admissions, for instance, after a typhoon in the Philippines. So yes, still quite some things to explore and to link out to other people who don't necessarily have a health background. Many frameworks, many glasses. I love frameworks, I really do. But a framework is a tool. It's a pair of glasses to look at reality, but it is not reality. So how perfect should your model be? Well, probably as perfect as it is to serve your goal. It is per definition a reductionist approach, some more than others, but it should help you to better understand and to steer reality. So from my side, a few tips or warnings. Most interesting are, I think, the interactions between different elements in a framework. Most interesting also are the effects from outside the system, although no system is closed. There's always permeation. And also look at the unintended effects of anything you change in that system. Well, you've seen all the possible. I will now walk you shortly through the framework, which is in the booklet I showed you. And I'll show one example of how it was used already a long time ago to analyze changes in a health system. This framework shows a central axis of leadership and governance, service delivery, and outcomes. And service delivery is intentionally linked with and overlapping with the community, because it's not only the health providers which produce health, but it's the population which does most of that. And population also overlaps with resources, because ultimately they pay for health, they vote for governance that decide on health. So it's all linked. And ideally, they also determine or co-determine what is in the health system. Very explicitly, the values and the principles underlying, it really helps to think about conflicting values. And there are ample examples from United States, for instance, where you can discuss how that is different for different actors. There are people who really look at healthcare as a profit-making system, and indeed it contributes to GDP to a large extent. So also from a revenue perspective of the government, very important to think about that aspect. Or an employment system. I think they have calculated in Europe that by now, I think is 1 out of 7 people in the employment age who are working in the healthcare system, but in 20 years from now, it will be 1 out of 5. And we are already short of human resources. Distribution system, market system, well, social support system, all of that, all of your perspectives reflect a value system underlying. Then the context is a big thing around it, but very important to look at how that influences the system, because the health system is shaped by the society it is in. And also, we call that path dependency, by the history in which it evolved. There's no way you can overhaul the national health services in the UK, although there are pretty well attempts to that right now, I think. I think that's mainly it. The arrows are bilateral because all of them have feedback loops and non-linear effects, unexpected effects. This is an example of how one of my Indian colleagues used the framework to analyze the delivery of chronic disease care within the local health system of a poor urban district in Bangalore. And I thought I had good things. Anyhow, it's a bit populated. He wrote in the outside element that there is urbanization and internal migration, which means that many new people came in without any residence, and that this also led, together with a big urban growth and growth of industry and big infrastructural projects, which led to health facilities being displaced out of reach to many of these people who came in. At the same time, a rise of chronic conditions also linked to urbanization. So that led to that it was very difficult for services to provide accessible care to people, or even for the government to have an adequate overview of what was happening and where the biggest needs were. So the government could not plan well for the needs of their population health management approach, but there was a spontaneous evolution of markets and a big privatization of healthcare, also pushed by big numbers of medical graduates from all kinds of medical schools. So there was a supply of doctors who were looking for a living and started their own private clinic. So the healthcare delivery system became increasingly pluralistic, but without oversight from the government. The two subsectors functioned more or less autonomously. Whereas maybe in the government system, there was still kind of an oversight, but in the private subsector, there is hardly any collaboration apart for a few change with accreditation, which are the upper end of the private sector, but there is a big segment of individual clinics of all kind of variation in quality and size, which function without any integration with the rest of the system. So no oversight, not a regulating authority, and at the operational level, very little collaboration, for instance, about referrals or sharing data, or even collecting data and bringing them back to the government. So on the healthcare utilization side, people in that system, 80% of them use private healthcare services. But we couldn't measure, so very difficult to get an overview. The private sector had more resources, but charged on a fee-for-service basis. So out-of-pocket expenditure was very high and increased, and very little monitoring of quality of care and of continuity of care. So planning was not balanced, and the outcomes actually only got worse instead of better, despite of an increase in the number of doctors. Well, this is a bit a messy kind of adaptation of the framework. This looks already more neat. This came from a WHO report also on complexity of health systems. And people in Switzerland actually wrote this framework, and they modeled a bit more neatly a complex analysis approach, where they looked, in this case, it was a pay for performance initiatives for tuberculosis, and they mapped all the things which were happening, but also feedback loops and unexpected and unintended consequences. I think I walk you through a few. So it started with financing, right? They actually paid providers for being able to keep patients completing their tuberculosis treatment, because that's very important to prevent resistance. And at that time, the problem was that there were low rates of patients starting treatment, but even more important, low adherence to treatment. So patients would start but disappear. And the anticipated output was that if you'd pay providers, they would also focus much more on adhering patients, and we would increase the uptake in both elements, and that would then ultimately lead to coverage. Well, part of that happened. Adherence rates indeed increased in most of the programs. Costs also increased, because you had to pay for performance if performance paid well. Well, you had to budget for that. And to a certain extent was also effective. So the early intervention showed success, but later intervention showed unintended effects. And one of them was outcrowding other services, which were less lucrative. So other services got neglected, and while all the focus was on adherence, there was less focus on the quality of care. Also, the performance really steered towards incentives, external ways of motivation, not necessarily the inner motivation, which many healthcare workers also have, to work good because they like to work with patients and for patients. So that had a longer term, more detrimental effect on why people would retain in jobs, for instance. What else do we have? Oh, you do. Yeah, sorry. Yeah, so you see feedback loops. Also, I said there was much more attention on adherence to care, much less on the person-centered dimensions. So ultimately, the perception of people about services, not only the TB services, but also all the other services, deteriorated, leading to a feedback loop of ultimately decreasing, or at least mixed methods on utilization of care. The lesson from this diagram is that you evaluate not only the narrow intervention, which was the start, but you have to evaluate the entire system and look at positive and negative effects, the likelihood of effects happening, and the importance of them, because not all of them are as dominant as others. And it might help to look at subsystems first, because otherwise it becomes a bit of a spaghetti. That's this one. We try to apply this complex system modeling ourselves to analyze the barriers and facilitators in national health systems to scale up integrated care. This was work by Monica. And we used causal loop diagramming, which is a visual tool to depict interactions and loops and feedback loops between system components in a system. And the arrows indicate that a relationship. A positive arrow means that it's a similar direction relationship, and a negative relationship that it's a contrasting relationship. Well, this was the figure we made for Cambodia. And most central was that in Cambodia, so we wanted to scale up integrated care for diabetes and hypertension, but there was a lack of resources, which had a direct link with quality of care and the potential to scale up integrated care. And I think, well, oh, you have to also push because yeah. Yeah, I'll go the same. But even more, and that's a bit similar, of course, to what we saw in Bangalore, low quality was more prominent in the public sector, and healthcare workers are paid better in the private sector. So that leads to increased privatization, a rise in out-of-pocket expenditure, negative impact on access, and increased fragmentation and episodic care. So in the end, a negative impact on quality of care. I think that's the second subsystem in orange. Yeah. Yeah, I take longer anyhow, yeah. Yeah, so the weak governance systems, all the same, so we'll just walk through. I don't think it adds a lot more. Where are we? Yeah. Okay, this was a bit of a difficult diagram to understand. I myself, I'm trying to learn how to do this better. And Professor Jalali, about a month ago, gave a talk at the Soswi Hawk School of Public Health in the technique on how to do this systems modeling much better than we did, and how to balance between spaghetti models like the one you saw and models that really allow for better understanding. And he was extremely good in explaining step by step of how you build something analysis. And he starts with building the subsystems. And this example is in fact one of medication treatment for opiate substance disorder or disuse order, where he starts with very simple people who are untreated and people who are intreated. And this is a balancing vessel, if you want, and how they are influenced. Oh. And oh no, yeah, and you see in the upper purple circle, he shows that yeah, if you are in contact with the healthcare system and you are referred, then you get more people on treatment. But if you don't invest in capacity to take in new persons, then there is a limit of how many people you can take in. So ultimately, then you cannot move forward. He builds in the paper, he builds it up to become a much more complicated model But I could recommend, if you're interested in this technique, this is a really good starting point to see how to use the technique. That was, I think, my almost final slides. The take-home messages were, yeah, you can put them, I think. Health systems are many things, depending on the actor's perspective. They are definitely complex adaptive systems, but your task is to reduce complexity for understanding and for decision making. And when you step upon this roadmap, one step at a time, it's actually quite fun to do. Thanks.
Thank you very much for the presentation and the overview of all the different frameworks. Questions? Any questions online? Okay, so I'll start. Which one?
You choose. It's a menu.
The menu. How would you? I mean, I know I say the same when they people. No, it's a menu. But then so it's a menu. But I have an idea when I order chicken or a fish. I have an idea what I expect. And when people tell me it's a menu from very many things that I may not have used, I appreciate some additional guidance as to how. So I'm not posing the burden on you, and it's more a reflection that these frameworks tend to be thrown at the to the public and saying, "Get on, this is how things are done," and there is very little effort in trying to place them in the context of other frameworks, or actually to say, okay, these are the limits. So we shouldn't try to use it if you're studying, let's say, a small scale phenomenon, or if you don't think that, I don't know, because of the values that you are using, I mean, as part of your framework, in your health system, this is a value that is absolutely fundamental to this framework. And if you don't think this is what you would be, that would be relevant to yours, then forget about it. So I'm missing that people make an effort, and I don't know whether you share the impression, to help people use these frameworks, particularly considering there are many of them.
Yeah, well, I think in that historical analysis, we tried to position the different frameworks and show that, yeah, if you're very reform oriented and probably thinking about the financing stuff, then the control knobs frameworks are extremely useful because they identify not only the levers you have, but also give you the tools to measure the effects. And if you link them with the systems approach, you can do that in a less linear way as was done in the 2000s, let's say. So there is some guidance, but I think even more, so I think the frameworks I showed basically have a different focus, each of them. So that helps in terms of domains. Mm-hmm. But even more important probably is also the context which you evaluate. Is it a health system in Ghana, a national health system, or is it Indonesia, which is a completely different health system? I think that answers more. That's probably more relevant to think about what are here the distinguishing characteristics. Indonesia has 100,000 islands, so access there is a very different entity than Singapore or even Ghana. So I think apart from choosing the right framework for the domain you're interested in, it is how do you adapt any of those frameworks to the relevance of the local context and the key core problems at stake there.
Yeah, sure.
I also wonder if a flip of the question is, are there certain frameworks that you should not use to evaluate certain policies, or that are easier to gain to get the answers you want, essentially, if it'd be disingenuous? Are there some mismatches that you would warn against, as well as good matches?
Oh. I don't.
The reason why I ask it is because when I would teach about the Canadian healthcare systems, I would start students with the control knobs framework. But I found that by the time they got to the end of the semester, very few of them wanted to use that for their final papers. I agree with you, it's very good for financing, but for more complex things, it misses out so much. But if you really wanted to just accentuate the financing part, you could just use the control knobs and do away with the complexity, especially if the complexity is inconvenient.
Well, I think that's really, I mean, by saying, oh, it's so complex, you can never anticipate, that doesn't help anybody. So your task is to reduce complexity. And not all problems need this spaghetti. I think the spaghetti approach doesn't help at all. So yes, probably our health system dynamics framework does not, even many students have used it, but also many students have not used all the elements, and that's probably right, because otherwise you end up with the Bangalore framework, which was descriptive but still didn't help to identify, okay, which are now the key levers for change. And that's probably the first question you ask. Okay, you can map the entire system, but ultimately you are interested in what would be first knobs to turn upon, or what would be the most relevant one. So some kind of quantification in perception and in a participatory approach, because it's difficult to make those decisions as a technical expert from a desk. You'd have to do that together with the people who know the system. Like where is room for maneuver? And for instance, in Cambodia, we knew that the WHO had this massive funding program, so there was room for maneuver. But in Belgium, we had a similar diagram for Belgium. The maneuver was in that there was in fact a policy change towards an integrated care policy. So you need local knowledge to decide on what is the level and the starting point for your framework analysis.
I'm afraid we don't have much time for more. Because this is CRiHSP, and we are. I would encourage everybody in CRiHSP to realize that we will clarify in the coming months, weeks, if there's a preferred set of frameworks, framework that we want to adhere. But in the meantime, I think it's important to realize that whether you're doing an evaluation of a specific intervention, or whether you're considering, I don't know, a help-seeking behavior in relation to cancer, or whether you're studying teamlets, the finance, the human resources, the interest of the individual patients, all these things are relevant. So, and you can try to make some form of abstraction and pretend that very mechanistically there are only a small set of variables that are really important. Sure, but when trying to interpret your data, the results of your experiments, of your analysis, you need to benefit from a product framework. And because, yes, will be. Would you please join in thanking again Josephine for a fantastic. And thank you very much, everybody online, for joining today. We will make this available online, and also with questions and answers if they were. And we will share further information in relation to future seminars very soon. Thank you.